Hey.
Alright, you guys ready for the lecture?
No.
Alright, so this is gonna be a quick review of the anatomy of the nasal passages. So we are starting with the upper respiratory tract, and then we will move on to the thorax after this lecture. Okay. So just a brief review, nasal passages, as you know, they extend from the external layers to the cribriform plate, and then the cribriform plate basically joins with the vomer bone. And cribriform plate is a sieve-like which is between the nasal passages and the cranial cavity. So why this is important is because if there is any infection or neoplasia in the nasal cavity, you want to know if it is extending in the cranial cavity or not. So the best way to evaluate that radiographically is to look at the cranial cavity. If it is intact, it is less likely that there is lesion in the cranial cavity. Make sense? Okay. Nasal septum, it divides the nasal cavity into two chambers, like you know. Nasal septum fused plate. Vomer bone is the ventral aspect of the nasal septum, and this is a bony structure, as the name suggests. The turbinates, the ones that you will be able to see radiographically, are maxillary and ethmoid. Maxillary will be more linear structures, and ethmoid more coarse in appearance. So basically, try to finish nasal, pharynx, larynx, and trachea. How far we can go with this today? So skull radiographs, right? And they are difficult to, first of all, obtain without sedation or anesthesia. So whenever a patient is coming to radiology for skull radiography, that we need sedation or general anesthesia. Because otherwise you get the obliquity on those radiographs and you won't be able to interpret the superimposition of various structures in the skull. So we take for skull radiographs are a lateral view and a dorsoventral. And the supplemental views, depending upon what you are trying to image. So in this lecture, we are focusing on nasal cavities. So supplemental views are open mouth ventrodorsal and intraoral dorsoventral. Okay? And of course, the techniques which are more superior to radiograph are CT and MRI whenever we have that option available. So these are the standard views, and you can see here the patient is in the lateral recumbency, and the extra beam is going through the thickest portion of the skull. And this is the dorsoventral recumbency or view, and the extra beam is going dorsally and then down through ventrally. Okay? And this is how we position it. So like I said, lateral recumbency, and you focus on the thickest part of the skull, and then this is what you get. So make sure that the mandibles on both sides are superimposed. Look at the tympanic bulla. They should be almost superimposed, and that means you got a good radiograph, the lateral view. And then you can look in the nasal cavities. So like I said, maxillary turbinates are more linear in appearance. Ethmoid turbinates are more coarse in appearance. And then is the frontal sinus. You won't be able to see a lot of detail in the nasal passages on routine radiographs. So that's why when you see the MRI, if you are really looking into conchal detail and more detail about the nasal cavity. Soft tissue opacity, your soft palate. And soft palate basically divides the pharynx into two subcompartments. On dorsal to the soft palate will be nasopharynx, and ventral to the soft palate will be oropharynx. So the endotracheal tube is passing through the oropharynx. Okay, so all of this area is oropharynx. And this is nasal cavity and ethmoid turbinates, frontal sinuses. So at least you should be able to identify those structures and interpret those structures. Okay. If I go too fast, then please let me know. This is again hard palate, soft palate, And then, so soft palate is basically extending from here down to here, okay? And these radio-opaque structures in the background that you are seeing, those are hyoid bones. We will cover those later. And this is your, and we use those as landmark to make sure the lateral view is perfectly lateral. So they should be superimposed. Now again, nasal cavity, hard palate, soft palate, and then the structure here, the soft tissue opacity, which is extending cranially from the larynx towards the tip of the soft palate, is epiglottis. Okay, it should not go beyond the extension of the soft palate. It should be right at the tip of the soft palate. Again, this would be nasopharynx, which is dorsal to the soft palate, oropharynx, ventral to the soft palate. So these are the structures you should definitely know. This is a review of the hyoid bones. So as we know, there are 5 hyoid bones. Some people start with tympanohyoid. This is actually a cartilage. You may not see that on the radiographs because it's a cartilage, unless it is mineralized. So we start from stylohyoid bone, which is the longest, and then epihyoid, and then ceratohyoid, and then basihyoid. So remember, basihyoid is the one which is unpaired. So you are looking at basihyoid end on. End on is like, for example, if this is a pen, and then if I turn it like this, now this becomes end on. So if you see bones like this, for example, stylohyoid, you're looking at it like this. But basihyoid, you're looking at it like this. So that's why it looks more radio-opaque. Make sense? So compare it over here, tympanic bullet. Tympanohyoid, you are not able to see in this image. The longest bone here is stylohyoid, and this is a pair structure. You can see both of them. Epihyoid. Ceratohyoid, you are not necessarily seeing both of them here because probably they are superimposed. And then basihyoid looks more opaque, more radio-opaque because again it's end on. And then thyrohyoid here, and then the second one is fracture or things like that. Okay. The next structure would be the laryngeal cartilages or larynx. So the bone, this is a thyrohyoid from hyoid bone that connects with the thyroid cartilage, and then there is cricoid cartilage. There is also arytenoid cartilage, which is pretty much superimposed with thyroid cartilage. So you may not see them separately. So for example, over here, you can identify the bones, right? So this would be thyrohyoid bone, and then that connects with the thyroid cartilage. Arytenoid is also in this opacity, but you cannot identify them separately because they are superimposed. Further to that would be cricoid. This triangular-like structure would be the cricoid cartilage of larynx. And if there is mineralization of larynx that happens with old age, you may see increase of these cartilages, and that's normal if it is an older dog. Okay. This is just for review, and then so I'm not going to go over this again. This is for your practice. Feline skull, everything stays the same. It's more congested and more smaller structures as compared to the dog later, because now we are focusing more on the nasal cavity. Okay. So you can, like I said, the standard view for skull would be your dorsoventral, but you can also obtain a ventrodorsal, and they look exactly the same. Why is a DD preferred over a VD? So this is like a more oblique view of the skull, and you can see there is more superimposition of the structure. You need sedation or general anesthesia, because other diagnostic. Because everything is just superimposed, you cannot identify structures or what's going on. So make sure that the patient is or generally anesthetized, unless the patient is in coma or something like that. Okay. Yep. Question.
So, are the legs mixed on it? So the DB is going to be the lower line?
They are both obliques.
Oh, they're both.
Mm-hmm. But this one is an oblique, and this is a well aligned. On the previous slide, we have DV, this one is a DV and this one is a VV. Questions? DV is preferred. And why is it preferred? Like I said, you get obliquity more often on DV. Okay? But it doesn't mean you can get a perfectly straight. Yep. Yes, yes, yes. How they are positioned. So DV is just you easily get it more straight to a VV because it gets more difficult to maintain it in a straight position like that. Good.
That's, so is that correct waterline BB and then rather image?
Yes,
Okay.
that's how it should be. So this structure is endotracheal tube as well, which is in the way. So when we take skull radiographs, you make sure that the tube is actually not in place if possible. That also adds to the obliquity a little bit more. Okay. Alright, so a little bit about anatomy that you should be aware of. So there's the nasal septum, which is superimposed with the vomer bone. And then these will be the frontal sinuses, mandible, which we are not focused on right now, zygomatic arch, and basically just the nasal passages. So you are looking at the symmetry and the radiopacity or radiolucency. So just compare both sides and also correlate that with the clinical signs. Like if there is a unilateral nasal discharge versus bilateral, you should already have a picture of what you are going to expect in the radiograph. Okay. Now, like I said, for nasal cavities, you also add some supplemental views. So there is open mouth DV and intraoral DV. Those would be your two extras for nasal cavity. Why do we take those views? Because on these ones, the ones that we just showed you, there is also mandible superimposed on the nasal cavity. So with the supplemental views, we are trying to get rid of the mandible by making it open mouth and intraoral DV. So this is open mouth DV is obtained. So you use the gauze pieces and make sure the maxilla is parallel to the table, because that's what we discussed, right? With the artifacts, if it is not parallel, you will either get magnified or distorted view of the nasal cavity. So make sure the maxilla is as much parallel to the table as possible. The mandible, we pull it out of the way by using this gauze and see how the operator is using and wearing the lead gloves as well. And this is the direction of the X-ray beam. So you can actually tilt the X-ray tubes. So your direction should be towards the hard palate. Okay? And then this is what you get. So now in this image, there is no mandible. It's just the maxilla and the nasal cavities. There are turbinates which appear more linear than the nasal septum or lower bone. The ethmoid turbinates are more coarser in appearance, and then the frontal sinus is on the sides. Okay, good. And this you can practice by yourself, where the structures are. And this is the intraoral DV view. So see how the cassette is going into the mouth. And the thinner the cassette, the farther you can go to capture the entire nasal cavity. Okay? And this is the jam, you get the view without mandible in it. Okay? Another view is for the frontal sinuses, and we want to assess frontal sinus when there is suspicion that the cribriform plate is damaged. Because now you are concerned about extension of the lesions in cranial cavities, right? So for frontal sinuses, the end view or the frontal view or the rostrocaudal, it's the same thing, different names. So someone can say frontal view, you are doing the same thing as you do for skyline. Okay, just make sure you are aware. Rostrocaudal means that just the beam is going rostral to caudal. And then skyline is also because you're going through the frontal sinuses. So we are basically bypassing the nasal cavity, going straight for the frontal sinuses right here. And then this is the view that you get. Okay. And this is the normal frontal sinuses, so they should appear radiolucent. And if they appear radio opaque, that means it's diseased. This is for a cat, and the structures are exactly the same, but the frontal sinuses are more smaller in appearance and more flattened in appearance as compared to the dogs. Okay. Any questions so far? All right, good. Now for larynx and trachea, they are again best evaluated on the lateral views, but it doesn't mean that you should not take a VD. If you are concerned about any displacements of the structures, you must also take a VD or a DB to complement. Okay? But you always start with the lateral radiographs, right lateral and the left lateral. And the position of the larynx and trachea can be altered depending upon how you are keeping the neck. If it is too extended or too flexed, that can change the position of the larynx and trachea. And we'll get into that later. And like I said, mineralization of the cartilages, like tracheal ring cartilages or the laryngeal cartilages can happen with older dogs or cats. Okay? This is about trachea, so as you know, it's a radiolucent tubular structure that extends from larynx down to the carina. And where the carina is, it should actually divide the thorax into dorsal 1/3 and ventral 2/3 approximately. And diameter of the trachea is usually stays the same. Now here, as you can see, there is a small dorsal deviation of the trachea, right? Is that normal or abnormal? It appears abnormal because that's not what you expect with the trachea. But sometimes if the neck is flexed, it can happen. So whenever you see something like this, now think about the opposite. If the neck is too extended, you can actually see a dip ventrally of the trachea. Okay? So it doesn't necessarily mean it's abnormal. When you see this, make sure you take another view of the opposite side, or you can stay with the same side, but you make the neck in a neutral position. Or take that into account if the neck was flexed. And this is positional. Okay? Now this is a VD, and the trachea should be almost midline, but here you can see it is more deviated, more so on the right side. And this can happen in obese dogs or when there is a lot of mediastinal fat. So you see how much subcutaneous fat this dog has on the sides. You can see that. So there is a lot of mediastinal fat, which is actually pushing the trachea to the side. So sometimes things appear abnormal and they are not. So make sure you take into account how much fat there is, what's the position of the neck, before you say this is abnormal.
Yep. For the neck position or other like if I didn't system to do that, I want to be able to tell that someone has other.
Yes. So good question. So she's asking if she's not sure if the neck is flexed because she was not there when the radiographs were taken. How do you know? So you can either look at the other opposite lateral. So this is the right lateral. You can go to the left lateral and see if this is a persistent thing or usually it will not be because the position is going to change when you take the opposite lateral. So usually you will not see the same deviation on the opposite lateral. But if you are concerned about something underneath the trachea, just pushing the trachea up or dorsal, then you must write it in your report and you can tell them, please make sure that the radiographs were taken in neutral neck position. Okay? Any other questions? Okay. So like I said, usually the tracheal diameter stays the same size, but there will be some changes depending upon the phase of respiration. So during inspiration, it's more dilated towards the intrathoracic area, and during expiration, the trachea is more widened near the cervical portion. So when you're looking at a radiograph and there is discrepancy in the diameter of the trachea, then make sure you compare both the views. And ideally, we should have one on inspiration, one on expiration, but it's not always possible that we can try to get inspiration versus expiration views. Okay? Any questions so far? So that was a quick review of normal anatomy, and now we can start with the abnormals. So common abnormalities that you will see in nasal passages, they can be neoplasia, which is common, and you can also see infection, which is also very common, rhinitis, or foreign bodies. Now neoplasia is usually seen in older dogs, and rhinitis is usually seen in younger patients. That cannot occur in younger dogs, right? So rhinitis can be different kinds: bacterial, fungal, viral, or idiopathic. Fungal, most common in dogs, is aspergillosis and blastomycosis, depending upon what area you are in. In cats, cryptococcosis is most common. Idiopathic rhinitis is more common in cats than dogs. Foreign bodies can occur usually in hunting dogs. Alright, so let's see how they appear. Common neoplasia that occur in nasal cavities are lymphoma, especially in cats. Squamous cell carcinoma can occur in both dogs and cats. Fibrosarcoma, again, dog and cats. Okay. Radiographic things associated with neoplasia. So you will see soft tissue opacity in nasal cavity. And typically this is unilateral. So basically you are comparing the nasal cavities on right side versus the left side, and you should be able to pick it up. And depending upon how aggressive the lesion is, if it is aggressive, you will see bony lysis. So what bones are in the nasal cavity? There is vomer bone, and there is maxillary bone that may get lysed. So you should look at the bony structures. And then, like I said, whenever you are evaluating nasal passage, also take a look at cribriform plate, if it is destructive or not. Okay. All right, so this is an example. So compare these two nasal passages, this and this, right versus left. The right is more radiolucent. Do you agree? And left is more opaque. So which one is diseased? The left side. Because normally the passages should be filled with air. And then you have to identify what radio density it is. So remember the 5 radio densities? Air. What's next? Fat. What's next? Soft tissue or fluid is the same. What's next? Bone. And then the last one is metal. So this, what opacity you're going to call this?
It's more like soft.
Yeah.
Yeah.
Or fluid.
Yeah.
Right? Always remember those together. So soft tissue, for example, if it's a mass. Fluid, if it's mucus in the nose, right? So can you tell the difference based upon the opacity, if it is mucus or if it is a mass? You cannot, because they look the same. Okay? Now, like I said, for neoplasia, if it is aggressive, you will see some bony changes. And also, sometimes depending upon the size of the mass, you may see a deviation of the nasal septum to one side, if the mass is pushing on the nasal septum. Okay? But if it is a small size mass, you cannot really tell the difference. Now here, this is the cribriform plate. So can you identify this on the right side and that it is not as clear on the left, right? So now we can say there is destruction of the cribriform plate on the left side. Question?
If you have an overload of mucus, could that mucus kind of be covering it and cause that, or for sure we know it's probably some bone?
Usually you should be able to see cribriform plates if it's a good quality radiograph. If it is not, if it is oblique, things like that, you may miss cribriform plate. So to be sure, we always recommend a CT and an MRI because you may miss that on a radiograph. Okay? So what would you do next? Yeah, you should all, definitely, you will start with the clinical signs and if it's unilateral, bilateral, things like that. But then from here to further confirm if it is neoplasia versus rhinitis, you you need some samples. Okay, so biopsy would be your next step. So you can do a rhinoscopy and get some samples from nasal cavity, and then send it for cytology, histology, culture, and then you should have your answers. And you can also do a CT or MRI for confirmation. Okay. And since there was a destruction of cribriform plate, you should assess frontal sinuses. And now here, as you can see, the left side is more radio opaque as compared to the right side. So can you tell if this is a mass or a fluid-filled frontal sinus? So you're saying fluid, you're saying mass? Anybody on this side?
Looks like a
Is it mass or fluid?
basic.
I don't think it's right.
And why do you say that?
Maybe
On the
floating
right side,
around
you can
us
see it's
here.
pretty well delineated. On the left side, there's some little protuberance.
Like here?
Uh-huh.
Okay. That's a good observation. Can you all see that? There's some bony proliferation on the frontal sinus on the left side as compared to the right. So that tells me there is some bony involvement of the frontal sinus. It doesn't necessarily tell me if it's a mass or fluid. It could be one or both. Okay, because they are both same opacity. And I really do not see a well marginated mass. If there is a boundary or margin of the mass, then you can say like it appears like a mass. But fluid is like more diffuse in appearance. And a mass could be diffuse in appearance as well. So typically we say do a CT or MRI for confirmation, basically. You cannot really tell the difference. Okay? Because they are both soft tissue opacity. Well, now with the frontal sinuses, if it's a mass, that becomes a soft tissue. If you are looking for frontal sinuses, you want to do a CT. There is also a cost difference. CT is usually more cheaper than MRI. It depends upon what you have at your facility. Do you have a CT machine versus MRI? So you have to take those things into account. Usually we go with CT. MRI usually we stick with if you are suspecting a brain lesion. Like if I was suspecting more of a mass with like margins and all, clear margins, I may do an MRI in that case. But because I do not see a clear margins, to me it seems like it's mostly fluid. Okay. All right, and then there are some typical patterns which are associated with the nasal cavities. This is not a rule, but this is typical. So typically when you have nasal neoplasia, you will see soft tissue opacity along with some bony destruction. But you still need to do a biopsy. If there is soft tissue opacity without a bone destruction, that's typically infection or a less aggressive or any kind of a mass. Okay, you still need a biopsy. The third pattern is when there are destructive pattern or lucencies in the bone without increased soft tissue opacity. So there is just lesions in the bone, that's it. That's usually typical of aspergillus infection or fungal infections. Okay? So again, you need biopsies or CT or MRI to further confirm that. Or you can do a rhinoscopy and also look around. Because usually with fungal diseases, you will see a plaque in the nasal cavity. And then you can take samples from there. Good? Okay. So moving on to pharynx and larynx. So when we come to the laryngeal pharyngeal area, the lesions can be extramural, mural, or intraluminal because it's a hollow structure. Okay? So extramural means surrounding tissues outside the larynx. So you have to think about what lives outside the larynx. Okay? For example, there is thyroid gland in that area. There is salivary glands like thyroid and mandibular. Okay? There are lymph nodes like retropharyngeal lymph nodes in that area. Okay? Mural would be something arising from the larynx itself, which could be laryngitis, different kinds of polyps, could be cyst, abscess, something which is coming directly from the larynx, laryngeal tissue. The third is intraluminal, which is inside the lumen of the larynx, which is like going through the passage. For example, a foreign body. Okay. Let's see how they appear. So this is a normal and this is abnormal, of course. So can you appreciate this increased soft tissue opacity? Explain this. And what structure would come to your mind first? Esophagus is in that area, so there could be like a mass arising from the esophagus in that area. It's a possibility. Lymph nodes, thyroid, yep, all those things. So how can we really narrow down our list? For that, excuse me, what did you say? I'm sorry, I'm not able to hear the biopsy? Yes, of course you can biopsy, but before we go there, we have to first come up with a differential list, right? So to narrow down the differential list, you look for the displacement of the larynx. Like where is it getting displaced? Is it to the side? Is it ventral? Where is it getting displaced? So based on this image, you can tell the larynx is displaced ventrally. Can we say that? Because the soft tissue is dorsal to the larynx, pushing the larynx down. Do you agree? So now I have to think about structures dorsal to the larynx rather than ventral to the larynx. Because if there was something ventral to the larynx, you would see opposite. You will see a dorsal displacement of the larynx, right? So that's how you can narrow down your list. So for example, the most common structure that lives here dorsal to the larynx is retropharyngeal lymph nodes. So the first thing that you should be thinking about is something with the retropharyngeal area. And whenever there is a mass effect, by mass effect, I mean a soft tissue opacity with some clear margins around it. Can you see the margins of this? So it looks like a mass. It doesn't look like a fluid. Because if it was fluid, it should be like spilled everywhere. And it should be more on the dependent area rather than dorsal, if it was fluid, right? So when you see a mass effect, then you have to think about Chang. Just memorize this. Chang stands for cyst, hematoma, abscess, neoplasia, granuloma. When you see a mass, that's your differential. Okay? And then you have to think about where is the abscess coming from. Then think about the tissues which live in that area. So I would be concerned about a retropharyngeal cyst, retropharyngeal hematoma, retropharyngeal abscess, neoplasia or granuloma. And then you will do FNA to confirm what is it and how to treat it. Okay? Good? So like I said, you will be looking for displacements. In this case, it was ventral displacement, but for example, if it was a lateral displacement of the larynx, that can happen from mass effect originating from tonsils, larynx itself, or a thyroid gland can cause a lateral displacement. And make sure you take a BD or a DV view to really see the lateral displacement. Because here, you will not be able to appreciate the lateral displacement on the lateral view. You need a BD or a DV for that. Okay? Now, in this case, can you appreciate the cartilages of the larynx? The cricoid and thyroid, like we discussed earlier? It's more like irregular soft tissue opacity, but you cannot outline the boundaries of the cartilages, right? So that gives me a clue that most likely it's coming from the cartilages of the larynx, because I cannot appreciate the margins of the cartilages. So these would be your findings. Laryngeal margins are thickened and irregular. Can you appreciate that? So by irregular, I just mean you cannot see the outline of those cartilages. Okay? They are more fuzzy, basically. And there is some mineralization within the mass, Can you appreciate this mineralization here? Does it look different than this area? So this looks like a more soft tissue opacity versus this, which looks more like a bone. Okay? So there's mineralization within the mass, and the mass appears to be present within the lumen of the trachea as well. So it's extending in the tracheal lumen as well. Okay? And now it can originate either from the laryngeal cartilages or from the tonsils or any structures around this area as well. But more likely it larynx itself because I cannot see the margins of the cartilages. Okay? So that's how you can narrow down. But you need sampling to confirm what kind of a mass it is and then what's the prognosis. Okay? This is another example of laryngeal foreign bodies. So here, this is the foreign body, it should not be here, so this is like an extra thing which you are seeing. Is this radio opaque or what radio density would you give? Radio opaque, like a bone? Okay, that really does look like a bone, right? So you can say there is a mineral opacity ventral to the soft palate, do you agree? And also, you see these radiolucencies in the soft tissue? All of these speckles, this should not be here. So the reason why you are seeing these radiolucencies in the cutaneous tissue is actually emphysema. So this emphysema could be because of abscess formation due to the foreign body. So why is there emphysema? Because of abscess. Where is it coming from? I'm sorry. That's true, it may have ruptured and now there is like a fistula formation or there is contact through the outside and now the air is just getting in. Any other? There could be air producing organisms which are making all that gas within the abscess. And now that gas is just diffusing in the subcutaneous tissue. Okay, so gas producing microbes can cause this appearance. All right, there are some other common conditions like laryngitis, pharyngitis, which are more milder diseases. So basically, you will just see some increased opacity in the laryngeal area, but the next step will be doing a laryngoscopic examination. Okay? Laryngeal paralysis can also occur, and radiographs actually may be normal because you cannot really see the opening and it's more dynamic. So you may not capture it on the image and you may not even see the abnormality. But sometimes we see a difference in the distension of the laryngeal saccules. So this is normal and you can identify the saccules here. Compare it with this one. Does it look more distended? I mean, this is very subtle. You may miss that too. So for laryngeal paralysis, it's recommended you do a laryngoscopic examination. But you may see some changes that suggest there could be laryngeal paralysis. Okay. Any questions so far? Good.
So going back to the mass that was ventral, or that was displacing the trachea ventrally.
Mm-hmm.
So on a physical exam, you would palpate that mass.
Mm-hmm.
So are you just doing like a radiograph to like check the integrity of those structures just to see? Okay.
Absolutely, yes. So even though you can palpate the mass, we are just assessing how that mass is affecting the upper respiratory system. Like how much is the lumen still open, or how far has it affected the upper respiratory tract? Okay. Good question. Any other? All right, good. Let's move on to trachea then. So there are certain conditions that you will see. Tracheal stenosis can happen, and which just means there is a narrowing of the lumen of trachea. But just make sure here it's very focal narrowing. So you have to differentiate if it is focal versus it is throughout the length of the trachea. If it's focal, then we call it stenosis, and it can happen because of maybe a foreign body or a mass or a stricture or just tracheitis because of infection. Okay, but this is focal or local. It can happen also because of a previous trauma, maybe during endotracheal intubation, or some white wound in that area. Hypoplastic trachea, on the other hand, it's something that you will see throughout the length of the trachea. So this is not focal. And this is a congenital defect, which is because of incomplete development of the tracheal rings or incomplete development of the trachealis muscle, which is dorsal aspect of the trachea. And this can be associated with recurrent airway infections, and commonly this is part of the brachiocephalic syndrome. So remember those the other three areas: elongated soft palate, stenotic nares, diverted laryngeal vacuoles, and then hypoplastic trachea is the fourth one in that syndrome. Okay? So this is how the hypoplastic trachea looks like. So you see how it is narrowed throughout. It's not focal. And this is how the normal trachea should look like. And tracheal foreign bodies can happen, like in hunting dogs. They can aspirate the foreign bodies. And usually these will lodge at the tracheal bifurcation, which is also called as carina. So that's the most common location for tracheal foreign bodies. And if these are really tiny, they can also pass on to the main stem bronchus. Okay. Collapsing trachea is also another which you will see commonly, and this is more commonly seen in the toy breeds, like a toy poodle or terriers. And goose honking is the most common clinical sign that they come with. And this happens, this is a degenerative change basically, and usually you will see in older patients. So this is how the tracheal rings are getting collapsed and collapsed, depending upon what grade it is. For grade 4, there is a complete collapse. Okay? And this is how it appears. So it's more common in the cervical area, but it can happen in the thoracic, intrathoracic, or even the main stem bronchus. But the cervical collapse would be more common. Question?
So, like grade, do you grade how do you consider it a grade 2?
Yeah, it's just the grade 1 would be like a milder, so you can see this, and then grade 4 is like there's complete collapse. So this would be like moderate, so I would say 2 or 3. Okay. Any other questions? Okay. So whenever you see a case of tracheal collapse, you make sure that you take 2 views, one on full inspiration and the other on full expiration. Because like I said, there could be some changes in the size of trachea during inspiration or expiration. So as soon as a case of tracheal collapse comes into radiology, you know what to do, right? You take 2 views, right versus left, and then inspiration versus expiration. You can see the size of the trachea on all those phases. And sometimes there is a tracheal collapse and you cannot catch it on the radiographic images. And it happens in the dynamic tracheal collapse cases. So then you need image intensification fluoroscopy to identify the dynamic tracheal collapse. So we are purchasing a new machine, the fluoroscopy machine. So hopefully by spring it should be functional, or maybe even during fall. All right, and then also there is a pseudo collapse. So do not confuse collapse with a pseudo collapse. It's a pseudo collapse, and the reason why, because you can actually see the wall of the trachea. Can you see that? That is the actual wall of the trachea, and this is a soft tissue opacity, which is actually redundant dorsal trachealis membrane or muscle. So it's just a sagging membrane. See, there is a muscle on the dorsal aspect of trachea. Normally, that's how it should be. But in pseudo collapse, that muscle is kind of sagging down ventrally. And the most common location is mid-cervical to mid-thoracic. That's where you usually see it. Especially-
So is it actually pushing into the trachea or is it just covering over it what it looks like?
It's into the trachea.
Okay.
It's into the trachea, but you can still see the dorsal wall of the trachea. If it was a true collapse, I should not be able to see this dorsal wall of the trachea. It should be just completely narrowed down like this. Can you see the difference? And this redundancy of dorsal tracheal membrane is dynamic. So when you take the opposite view, opposite lateral view, it's gone. Because now it has shifted dorsally. Okay? So it's not a permanent or a static thing. It just comes and goes. Alright, we got it. Anatomy. I think you thoracic anatomy lecture from your previous. When did you have it? First year? Do you guys have that lecture? Okay, I'll post something on the blackboard for you to review, like a normal thoracic anatomy. And then on Friday, we can start with abnormals in the thorax. Okay? So make sure you review that so you can quickly grab the concepts.
Thank you.
All right, thank you so much.
Thank you.
Thank you.